Welcome to a discussion of KDIGO's new update of our CKD-MBD Guideline. KDIGO is a global organization committed to developing and updating guidelines to help clinicians treat patients with kidney disease. I'm John Davis, the Chief Executive of KDIGO. I'm joined by the co-chair and two members of the work group who created this update. This process actually began in 2007 with a KDIGO Controversies Conference on mineral and bone disorders, where the term MBD was actually coined. That led to a 2009 guideline, and then after 5 years, we held another conference looking at areas in the guideline that needed updating. Today, we're reviewing that just published update. The KDIGO guideline process is a rigorous scientific one, using an independent university-based team to review and synthesize the evidence. It's written by a volunteer work group, and everyone can make suggestions during 2 public comment periods. Sometimes there isn't enough evidence, so we write research recommendations, and there is no industry support or influence in the process. Joining me are the co-chair of the work group, Markus Ketteler, and work group members Geoff and Linda McCann. They are 3 of the experts who led this update. It covers bone imaging, new therapies, management of calcium and phosphate, and PTH lowering. So to get started, Markus, one change in this update involves bone quality. Tell us about that.
I think it's one of the important changes because it reverses what we said in 2009 by close to 180 degrees. We are all aware of the DEXA bone mineral density measurements, which is highly established in the osteoporosis guidelines, WHO relevant. And in 2009, we had to say that this method should actually not be used in CKD patients because it does not predict fracture risk and because it does not tell us about the bone phenotype, the bone disease that is underlying here. This has changed. So studies have been published in all stages of CKD, including in the dialysis patients, that show definitely that it predicts, the DEXA scan does predict the fracture risk in all these populations. And I think this is something quite useful because we are all applying therapies to these patients, and we could possibly use this method also to determine the success of these therapies. We still have to keep in mind, and this is still true from the last guidelines, the DEXA scan does not tell us whether the patient suffers from renal osteodystrophy, from adynamic bone, from high turnover bone disease, osteomalacia, or classical osteoporosis. And this, of course, has to be considered when we make our therapeutic choices. But still, we have now a tool that tells us about risk, and it may tell us about the success of the individual treatments. And we should try to make use of that.
Yeah, and I think, Markus, that one of the most important points that you make there is that the nephrology community has been reluctant to consider anti-resorptives or the denosumab. And I think that the guideline summary and the guideline rationale it really makes it quite clear that we have gained a lot of clinical experience using bisphosphonates in patients with CKD. And while there has been a theoretical fear of adynamic bone, there really hasn't been any evidence of inducing adynamic bone. And the rationale is quite clear that it says bisphosphonates we know induce low turnover bone, and yet they reduce fractures. And fractures are a tremendous problem for our patients. And so I think we encourage clinicians to think about whether or not bisphosphonate, anti-resorptive, or not just bisphosphonate, anti-resorptive or denosumab or other therapies might be beneficial for our patients. And that really represents a big change for us.
And as the population of our patients changes, we have more and more elderly on dialysis, sometimes not with a year-long course of CKD, but just with some impaired kidney function. Then there is surgery, sepsis, or contrast media intervention, and then all of a sudden, an 80-year-old lady is on dialysis and has a fracture, and this 80-year-old lady will, for example, or might, for example, have osteoporosis and would benefit even from these more classical treatments. still, if we have the younger patients, high PTH levels, for example, they might, if a fracture occurs, they might very well benefit from the suppression of the PTH. And then we could see what the therapy does with the bone. Because when the bone mineralizes under this therapy, we probably did something good for the patient.
You know, that brings up two important points. One is the bone biopsy, because the 2009 guidelines basically listed 4 or 5 things of when you should consider a bone biopsy. This guideline acknowledges the utility of a bone biopsy, and actually we encourage more clinicians becoming familiar with and using it, but get away from the notion that you have to have a bone biopsy before you consider anti-resorptive therapy for your patient. And I think that we acknowledge that the epidemiologic evidence suggests that in the general population, osteoporotic fractures are being reduced. In the patients with CKD, they're actually increasing over the last 15 years. So we encourage that if you have uncertainty, a bone biopsy is perfectly appropriate, but you don't need to wait to get a bone biopsy before you consider anti-resorptive therapy.
Yeah, just fully agree.
Taking into account the patient attitude about all of this stuff, fracture risk must be a big concern for patients, but also the bone biopsy probably isn't something they enjoy. Talk a little bit about how the work group considered the patient attitudes.
I'm not sure that the fracture or the fear of biopsy is at the forefront of the patient's concerns. I think this is such a silent disease for them. Mm-hmm. They don't really recognize, they don't feel any different when their chemistries are a little bit out of whack. You really have to try to bring it to their level to help them understand that there are some things happening behind the scenes when all of this is going on. Certainly, we know elderly people are much more aware of fractures and the concern with that. Our patients tend to have a much worse outcome with fractures, higher mortality, higher morbidity, end up maybe being discharged to a skilled nursing facility. So it's not something they want to have, but I'm not sure it's in the forefront of their mind. I think there's a lot more focus on fall prevention now within dialysis clinics, which is really a good thing. And having this information to know which patients are most at risk allows us to target those patients and make sure that they have the type of support for avoiding falls and other support, medication support, to try to prevent those fractures.
I mean, we have those biomarkers. PTH, calcium, phosphate, alkaline phosphatase as well. We look at the vitamin D status. And sometimes we have quite plausible constellations of those, and sometimes they are completely inconclusive. Mm-hmm. And the latter population is the population which is prone for bone biopsy, especially if they had events. The other population where we are a bit sure, although the patterns are difficult to interpret still sometimes, we can start a treatment and then look at the follow-up, what happens to the patient. So let's say after a year we repeat the DEXA scan and we see, well, there is T-score went from -2.7 to -2. We did something good. We were good physicians. If it doesn't work, we still have the option of the bone biopsy, which is a very hard readout of what is happening to the bone and will then guide us to therapy. Given the problems that in some areas, some regions, skilled pathologists are not all available, and also the technique got lost a little. But we just wanted to counteract that trend and reactivate the use and the usefulness of this method.
Yeah, I mean, John, it's a big change, right? This is a big change. This work group recommends the use of DEXA. Now, we couch it in the term, if it will change the clinician's behavior. But tacit in that and reading the rationale is that we want the clinician to use all of the tools, get the DEXA, look at these biomarkers that are available to us, right? And individualize your therapy for that patient over time, as opposed to blanketly, the 2009 guidelines basically said, don't get a DEXA, and manage any PTH above normal. This guideline, in fact, is quite different in that regard, and I think clinicians need to absolutely be aware. We recommend DEXA, we recommend it over time, and we recommend it if it's going to change your behavior to consider therapy that reduces fracture risk. What you asked Linda, this work group, Linda and I had the privilege of being on the 2009 work group, but this work group in particular really took to heart the concept that it was the patient-related outcomes that mattered, right? Not are you treating PTH or are you treating phosphate? In fact, this guideline work group, made some substantial changes with regard to not just targeting particular biochemical, parameters as what clinicians should be doing.
Mm-hmm.
And it's always interesting to see what the reaction is from our colleagues, where particularly with bone biopsy, there's still, why did you tell us we have to do there's a relief that we're saying you don't have to do it before you start anti-resorptive therapy. But also a question, why are you still saying we need to do this when nobody can do it, that hurts the patients, this, and this. And I think the group was reluctant to abandon that, knowing that that's the gold standard. If we abandon that and say that it doesn't matter anymore, there will be fewer and fewer and fewer, and we won't have the possibility of getting good data, which helps us identify which laboratory markers are associated with those bone states based on that bone biopsy. So there were several people that said, why are you asking us to do these bone biopsies? But again, you don't want to lose the gold standard in the long run. You don't want to go away from it just because people don't necessarily want to do it or don't have all the knowledge. Maybe that's going to stimulate people to get the knowledge and to really bring that back.
Well, the bottom line is it's not a terribly invasive procedure, right? And the work group acknowledged that. And there's a wonderful table in the rationale later in the guideline that looks at the sensitivity and specificity of PTH for diagnosing or introducing therapy, either withholding therapy or initiating therapy. And this table basically is giving clinicians direct guidance. When should I stop my therapy or when should I start my therapy? And the positive predicted value and the negative predicted value of a PTH. And we only have that table because we have bone biopsies with which to establish sensitivity and specificity of the assay. So it's quite important.
Absolutely.
You also recommend not basing treatment decisions on a single lab test. You talk about testing over time and measuring change instead of one particular lab test on a particular day.
Probably Geoff should answer that because he did the study.
Well, yeah, absolutely. In dialysis patients, I think that it's really clear that there are some issues related to when you're measuring these things, whether what time of day it is, and as we point out in the guideline, everything you do affects more than one variable. Right, so trying to target a single variable inevitably affects the others, whether it's dialysate calcium, which might lower PTH, or it's vitamin D therapy that might reduce PTH and change calcium and phosphorus. So there are a couple different issues, but one is we should look at them together, not as single variables, but as a phenotype. And the second is our therapies are not without consequences. And I think this is an overriding theme we'll talk about, that we acknowledge that the current standard where we use calcitriol or that's analogs routinely has consequences. The use of phosphate binders in people who don't have hyperphosphatemia, for example, which is what the previous guideline recommended, has consequences. And though if you're going to institute a therapy that has consequences, you should be pretty darn sure of what it is you're treating. And you can't do that with a single variable of calcium or phosphate or PTH. There is tremendous change over the course of a day. There's change over the course of time. And so our recommendation is consistent with the fact that if you're going to institute a therapy, it should be based on a reasonable likelihood of benefit and mitigating or minimizing harm. So I get asked by my colleagues all the time, what do I do with a phosphorus that is 5.1 in a patient with stage 4 CKD or PTH of 140? And my answer is, let's see what happens over time, right? Measure it again in 3 months. If it's 3.7, then I wouldn't do anything. If it's still, or 4.2, everybody's a little different. But I think we really encourage clinicians to not overreact with therapy until they're positive they have a benefit.
What I always like to remind myself and colleagues is that we are not treating lab values. We are treating either disease or symptoms. And this is, I think, very important because if we have an elevated PTH and no bone disease to go with it, we can be pretty relaxed. One thing that I found in your study quite telling was when you were especially looking at the high PTH levels in these 26,000 dialysis patients, and you looked at the same time at the calcium and phosphate levels. Once the calcium and or phosphate was elevated, the PTH predicted mortality risk. Once the calcium and phosphate was pretty well under control, there was no mortality prediction anymore. So also this shows how interconnected these parameters are. And as you already pointed out, if you lower the phosphate, the PTH may go down. If you lower the PTH, the phosphate may go down because part of the phosphate comes from the bone. And all these things we have to internalize much more and to really become a little bit patient to look at these trends by serial assessments of these parameters, because only then we see whether there is something going on or not. And I feel that it's a new guideline, the 4.1.1, is a good step forward to emphasize a big problem that we suffered from in the past.
One thing I want to ask about, Linda, is as a dietitian, one of the issues is phosphate and dietary intake of phosphate. You must have considered that pretty carefully, and what did you think?
Yes, we did. Even in the first guideline in 2009, when we came back from our original work group review, we've found that there was not a lot of evidence to support restriction of dietary phosphorus. Only 2 studies met the criteria that we would use. And they did show that you could reduce phosphorus, serum phosphorus, by intense counseling with the patient, but they didn't document any hard outcomes. So it made the evidence fairly weak. It makes sense biologically, plausibly, that we should be looking at the amount of phosphorus in the diet as well as the sources of phosphorus in the diet. And so certainly we want to continue to think about that, recognizing that it may not fully correct serum phosphorus levels. Geoff did a reanalysis of the modification of diet in renal disease study to look at those patients who had low phosphorus intake and whether or not that really affected the serum phosphorus. And what he found was that there was very little change in the serum phosphorus even with these low phosphate diets. Doesn't mean that there's no benefit to looking at the amount of phosphorus, but we have a couple of things that we need to consider there, one of which would be the source of the phosphate in the diet, making sure that we know where it's coming from. There's a little bit of difficulty because the food composition tables do not include the phosphates that are there from the additives. So if I'm doing an analysis of what someone's eating and I'm using the food tables in European or Australian or US, they probably are not very accurate in terms of estimating the phosphorus intake. You can figure that if the patient is eating processed foods or partially cooked processed foods or foods with a lot of additives, they're going to get 50, 70, even 90% more phosphate than they would if they were eating natural foods that are cooked from scratch. So we have to look at that. We also know that the amount of phosphorus that's absorbed from different food sources is different. So 40 to 60% of animal phosphate can be absorbed. Probably only 20 to 50% of plant phosphate is absorbed because of the phytates that are there that we can't really break down. Now that can be changed with processing. So there are certain things that can happen that could break those down and make them more available. But in general, what it does is challenge us with our previous low phosphorus diets where we said that beans and nuts and legumes were really off limits because of the phosphorus levels. And now we know that they're not as well absorbed, so they could in fact be really good sources of protein, especially for those patients who have an aversion to meat. We can get their protein levels up with some of the other ones as long as their potassium is not a problem, since those foods are typically high in potassium as well. But I think it just challenges the dietitian to not be so focused on what the numbers are, not be so dogmatic about the absolute level of phosphorus in the diet, but to really help the patient understand how to make the best possible choices. So if you're going to McDonald's, which you're going to do whether I think you should or not, if you choose the grilled chicken breast instead of a breaded chicken breast, you're going to get a lot less phosphorus. So really looking at the individual patient, what they eat, what their eating patterns are. We're not going to change those fully. We just need to work with the patients a little more closely, help them understand. And one of the areas we talked about is in the labeling and teaching patients how to know when there are phosphorus additives. And there have been a couple studies that were done where patients were taught to look for the PHOS on the label to know that those foods might be higher in phosphorus, and they were fairly successful. I guess after many, many years in this field, I have such a heart for the patients that I want to make sure that I'm allowing them to eat as naturally as they want, but giving them some guidance about what might be better choices.
If I could say, one of the things that we took for granted because it seemed biologically reasonable is that the 2009 guidelines recommended limiting dietary phosphate intake. This guideline has a few changes. While we continue to recommend that, first off, we have now some randomized controlled trial data of phosphate-lowering therapies in patients not on dialysis, right? And which we didn't have before, and I think this is a big difference. We presumed that an effective phosphate-lowering therapy would reduce phosphate intake, reduce serum phosphate, reduce FGF23, and help patients. Well, that's now been tested in at least 3 different trials, and unfortunately, there's not that direct link that we can demonstrate between giving people phosphate-lowering therapies and what happens to their serum phosphate in a non-dialysis patient. So that's a big change. I think that this guideline committee acknowledges it's likely that this recommendation is beneficial, but we have limited evidence and there is potential for harm. And so one of the big changes with this guidelines is we no longer recommend phosphate-lowering therapies to maintain normal serum phosphate. We recommend using phosphate-lowering therapies of a variety of things to reduce serum phosphate towards normal. All right, and that may sound subtly different, but it's an important difference. I think many of us believe that a serum phosphate that stays in the normal range is likely to be beneficial, but we hadn't anticipated the harm that comes with trying to do that. And you know, this evidence review was pretty rigorous, and if there's no evidence of benefit and there's evidence of potential harm, this work group felt that we shouldn't recommend it.
I think that's one of the really major changes that occurs. So going from a preventive approach in very early CKD to become a little bit more relaxed again. And I would just like to line out a little bit why that happened, and we were both involved in that study, the phosphate normalization trial. I think the idea behind it was based on the fact that patients, for example, start to calcify rather early in the CKD course, and that phosphate is linked to that. So patients with a GFR between 45 and 20 mils per minute were included, who just had phosphate levels in the upper normal range, most of them at least. And they were treated with 3 different phosphate binders, lanthanum, sevelamer, calcium acetate, grouped together in one active group and compared to matching placebo for, I think, 9 months it was. And the results were really, to us, also a big surprise, I guess. That first of all, the phosphate levels went down, but just a little bit, despite high doses of the binders. Same as with the diet, same as with any intervention. Second, the regulatory hormone did not move, the FGF23, in this early stage of treatment. And third, there was progression of coronary calcification, but not in the placebo group, but in the active group. Then, of course, we looked into the 3 different arms, and it was quite obvious that this was mostly due or exclusively due to the calcium load, but lanthanum and sevelamer were not better than placebo. And I think this is a very firm evidence for this new recommendation to treat hyperphosphatemia once it occurs. And going back to the new 4.1.1 guideline, that means that you should probably at least look twice to start this treatment. And I think this is very reasonable and something new, a new thought in this direction.
You know, and we were scratching our heads, honestly, as to why this might be. And this is why science, why the KDIGO has to be evidence-based. We now have a better understanding. You know, Markus, at this year's your EDTA meeting, where we now know that these medicines might affect the absorption of vitamin K, for example, and that might be why our active group actually did a little worse than our placebo group with regard to vascular calcification. So the bottom line is this work group felt pretty strongly that we needed evidence to recommend something, and in this particular case, the evidence suggested there was potential harm.
But still, once we have patients with hyperphosphatemia, we should treat. Right. And they are also new in the guidelines. We have new evidence, and actually hard evidence, because there were a couple of other trials that showed a benefit concerning all-cause mortality and even a trend to a benefit for the progression of renal failure in CKD patients not on dialysis, but hyperphosphatemic patients. Mm-hmm. And from actually the same group, a study, 3 years, dialysis patients, close to 500, showed especially improvements in cardiovascular outcomes when comparing calcium-free versus calcium-based phosphate binders. So in those patients, at least the choice of the binder makes a big impact, obviously, on the outcomes of the patients. And this is then another change in the guideline where we kept the text, the wording of the previous recommendation, restricting the dose of calcium-based binders, but we deleted all qualifiers, which previously were hypercalcemia, vascular calcification, or adenemic bone disease, because in these two studies, the patients were just all over the place. They were not differentiated by these such qualifiers. One could say then, why did you keep with restrict instead of saying avoid? And at least from my point of view, and I think our point of view, but you can possibly comment on that, there are two reasons. Reason number one is that there are areas in the world where there are no calcium-free binders available, but just calcium-based binders. And at least from epidemiological trials, for example, such as the COSMOS trial from Europe, it seems that it's still better to treat hyperphosphatemia with a calcium-based binder than not treating hyperphosphatemia at all, at least in dialysis patients. And second, all these studies had rather high doses of the calcium-based binders. These were up-titrated monotherapies, and we don't know where is a threshold. If you are successful with a low dose or whether you use the calcium-based binders in combinations with the calcium-free, we are not so certain whether they are really harmful. So this is the rationale behind this also modified guideline from 2009 to 2017.
But let's be clear about something. This is a big change, all right? Mm-hmm. There are some big changes that we've mentioned so far. This is one of them. We suggest restricting the dose of calcium-based phosphate binder therapy, period. Mm-hmm.
In patients with progressive and persistent hyperphosphatemia.
Yeah. So I think that the recommendation to use DEXA, as Markus said, to identify patients at risk for fracture, the recommendation to have dietitians focus not just on total phosphate in the diet, but absolutely spend the time necessary about how is it, where are they getting it, where is it coming from. The recommendation to restrict the dose of calcium, I think these are all big changes. And then we'll talk, I'm sure, in just a second about the issue of PTH management in non-dialysis and dialysis. We have another pretty big change.
We agonize over which words are used when we write these guidelines, because there is a desire to make sure that it's so clear that it won't be misinterpreted. Another thing is that with the calcium, the public review, there were many people asking for what is the top level of calcium that our patients should have. And we couldn't really give them that answer. You know, it makes logical sense that you wouldn't necessarily want a kidney patient to have more than what would be the upper tolerable limit for someone without kidney disease, but there was no evidence for us to be able to say that if the patient got 1,500 or 2,000 or 2,500, that any one of those was going to be the absolute number that would throw them into hypercalcemia or increased calcification. But it was something that, another area where the public review asked for more definitive information, which we did not have with evidence, so we weren't able to really give them that number.
Yes. So let's move to that issue then, vitamin D and PTH lowering therapies. What were the changes and what are the recommendations now?
Probably the biggest change is a very subtle one in the guideline. I mean, incredibly subtle. We changed the order of the available therapies with regard to if you're going to institute PTH lowering therapy in a patient on dialysis. We recommend that either calcimimetics, calcitriol, or their analogs, or a combination of both are appropriate first-line therapy. That is a subtle change from the way it used to be worded, and sort of diminishes the very lengthy discussion we had about the EVOLVE trial.
Right.
So this was not a guideline that we originally intended to look at, but we felt like the work group felt that the EVOLVE trial, which is a nearly 4,000 patient trial, randomized, controlled, placebo controlled, with adjudicated endpoints that matter over 4 years, that while the primary endpoint wasn't clearly positive, the aggregate of evidence suggested benefit in an adjusted manner and in a subgroup analysis, and at least the majority of the work group felt like was the kind of evidence we need in our field to give us guideline recommendations. So that, I think, is a subtle but important one, that the work group felt that there was good evidence to suggest that all of these are appropriate first-line therapies. The second changes with regard to PTH management has to do with the treatment in non-dialysis patients.
Right.
We acknowledge, the work group acknowledges two important things. We don't know what the PTH should be based on evidence in non-dialysis patients, but there is clearly some line between adaptive physiology and maladaptive pathobiology. And we suggest the clinicians should absolutely not simply treat everything back to normal, that there is some degree of adaptive hyperparathyroidism. The second is, today, the current practice paradigm is, if somebody has a high PTH, you look at their 25D, which is appropriate, and we encourage that. But right now, the therapy we have sort of barely gets 25D levels up to 20 to 30 nanograms. All right? And then most clinicians, if the PTH is still high, will institute calcitriol or something like it. This work group very clearly says we recommend against that. This is a huge change for clinicians. And it's going to represent an educational piece that we have to get across, which is these therapies have consequences and harms, and no offense, but serum calcium is not a barometer of calcium balance. And this work group spent a lot of time talking about the excellent calcium balance studies that have been done by Hill and by Peacock and by Spiegel, and a nice dialysate calcium study in dialysis patients, all of which suggest that positive calcium balance is almost certainly happening, and that the therapies like calcitriol create a positive calcium balance and a positive phosphate balance, well, we presume a positive phosphate balance, and shouldn't be given routinely. So I'll stop there and let you.
2 comments. First of all, dialysis. I think what we didn't address this time, and this was already decided in Madrid at the Controversies Conference, is the range of the PTH levels in dialysis patients, 2 to 9-fold the upper range of the normal concentrations. And this was indirectly a little bit even more confirmed by the EVOLVE trial, because in the ITT population comparison, CINACALCET versus placebo, there was no difference in mortality, despite the one group of patients had a PTH over 5 years of above 500 and the other of below 300 picograms per ml. Not an intended endpoint, more an association, but some that even strengthens that this range is possibly quite safe. The other thing is about the CKD patients not on dialysis, that we are thinking in the concept of adaptation and maladaptation, physiology and pathobiology. And a PTH that may be up by 2 to 4-fold the normal range of the assay may be perfectly adaptive, unless it is not constantly rising, unless it is not associated with severe hypocalcemia and other symptoms of a deranged mechanism. And in clinical practice, when we see patients with a GFR below 60, below 45, the first thing, and Geoff mentioned that already, should probably be to reconstitute their basal vitamin D status to levels of 25 OHD of 30, 40, 50, around that margin. And what you observe there in clinical practice is usually that the PTH freezes. It stays elevated, but it does not go up until very late stages. And when you are at these very late stages and the PTH goes up, maybe the calcium drops again, then it's still the time to work with the active vitamin D analogs with calcitriol. But then you are in a situation of severe and progressive hyperparathyroidism. And this must be discriminated, because otherwise we possibly shut down protection. We shut down protection from calcification, from phosphate overload, from calcium overload. And this is just what we wanted to say with this, I think, strikingly different guideline from the ones we had in 2009.
Everybody wants a number, John,
Yeah,
you know?
right.
And we specifically chose the term that you should treat if it is severe and progressive, acknowledging that that will be different in different parts of the world. You know, as you know, the Japanese have a very different PTH target than the KDIGO recommendations. But the bottom line is we wanted to have every part of the world think how they meet that particular definition, whether that's a PTH that's 150 for me or 230 for Markus, or whatever it may be. A PTH that goes from 30 to 60 to 90 to 140, that may deserve therapy of some sort, 25D replacement, or, you know, as you said. But a PTH that is 115 or 120 and not changing, that may not. All right, so I think that was part of our message.
Absolutely. One more issue that is connected to this very clearly, because the harm was associated, thought to be associated with the overcorrection of PTH, especially in the CKD-MBD patients not on dialysis, was a hypercalcemia risk. Actually, when now looking at the numbers for calcium, the previous guidelines suggested for all stages to keep the calcium in the normal range. The new guidelines now also have a, I think, significantly different view, especially concerning those patients on dialysis. Because there we now have, since many years, the option to treat with calciumimetics, and calciumimetics lower the calcium. And again, back to the EVOLVE trial, it was shown that many of these patients will develop mild and usually asymptomatic hypocalcemia as a treatment effect, as a part of the mode of action of the calciumimetics. But if we would have stayed with the previous guidelines, we would have had to supplement those patients as much calcium to get them into this normal range. And this could have taken 1-2 grams of calcium, a positive balance, a potential overload. And this is why the new guidelines just says avoid hypercalcemia. And this means to individualize the treatment concerning hypocalcemia. And if you have mild asymptomatic hypocalcemia, especially associated with the CINACALCET treatment, you can probably better leave it than supplement. Still, if you have a patient who is severely hypocalcemic, symptomatic, or has progressively rising PTH levels, you have to do something about it. And then you can use, let's say, calcium-based binders or plus vitamin D. So these are completely different situations. I think it is quite well explained in the rationale of the guidelines. But this is what's behind this also, I think, bigger change.
Yeah, it is a big change. You know, this concept that mild asymptomatic hypocalcemia does not need to be intervened. Yeah, and I think, to be honest, that's encouraging for clinicians. That clinicians want, you know, that's one area where we were at least able to say, here's how you should practice. We think. You know, we should be clear that our recommendations are a bit, they challenge the current standard. The use of DEXA, against the use of routine use of calcitriol, the limitation of calcium. These are things that are going to have a practical and should have a practical change in behavior for docs. The public review, it was remarkable how many people wanted us to use non-evidence base, right, to support what we do currently. And the bottom line is we acknowledge that we might be challenging clinicians to think more carefully, but that's what we should do.
But still, each of the reviewers, the public ones, had to, or did tell you whether they agree or disagree with the recommendation.
Right.
And even this one with the not routinely used calcitriol, there was about 85% agreement. Yeah. And with most of the others, it was in the range of 95% agreement. So this, let's say, was a confirmation that we probably were close to what we were able to say in the end.
Well, that's the process. That's what we use. So for the audience who watch this, the way to access the entire document, to read the new guideline, to read what the changes are, it's on our website, kdigo.org. Go there and you can read all of this information. It's also in our app that you can access with your phone, and there'll be educational tools which we'll provide and put on the website and distribute around the world. We want you to be able to use this work in your clinical practice. So we hope you take advantage of those things. I want to thank the panel. These experts are volunteers and have given of their time and their talent to make this come alive for you around the world and to really help us improve outcomes for patients. I want to thank OPKO, the company that made this video possible, and I want to thank the audience for watching and for participating in this process. All of those people who wrote comments, all of the people who listened to talks about this, we hope it will help you, and most importantly, will help your patients. Thank you.